नमस्ते आदरणीय व्यक्तित्वहरू। आज मैले नेसनल न्यूनेटल हेल्थ स्ट्राटेजी चाहिँ यहाँहरू समक्ष वाचन गर्न गइरहेको छु। फ्यामिली हेल्थ डिभिजन, डिपार्टमेन्ट अफ हेल्थ सर्भिस, पोस्ट 2060 जनवरी 2004 मा चाहिँ नेसनल न्यूनेटल हेल्थ स्ट्राटेजी चाहिँ नेपालको बनेको छ। मैले यो फ्यु वर्ड्सहरूलाई यही नै स्किप गरेको छु। एब्रिभिएसनलाई पनि मैले स्किप गरेको छु। टेबल अफ कन्टेन्ट यहाँहरूले हेर्न सक्नुहुन्छ, यसलाई पनि मैले स्किप नै गरेको छु। यसमा चाहिँ इन्ट्रोडक्सन, गोल, अब्जेक्टिभ, स्ट्राटेजिक इन्टरभेन्सन, रेफरेन्सेस, डेफिनेसन्स, एनेक्स रहेको छ। इन्ट्रोडक्सनमा इन्ट्रोडक्सनबाट वाचन गर्न गइरहेको छु। Every year, globally, an estimated 4 million babies die before they reach the age of 1 month. Nearly the same number die in the late pregnancy or are stillborn, and these rates are rarely recorded. Millions more are disabled because of poorly managed pregnancies, deliveries, and neonatal care. Deaths are far more likely to occur early in the neonatal period. This has been neatly summarized is the two-third rule, which states that approximately two-thirds of all deaths in the first year of life occur in the first month of life. Of these deaths, approximately two-thirds occur in the first week of life. Of these deaths, approximately two-thirds occur in the first day of life. Perinatal and neonatal outcomes are inseparable from women's health status and the quality of care available during the pregnancy, delivery, and the postpartum period. Complications that affect women during pregnancy and childbirth is also affect fetal and newborn health. Annex 6. The mother and her baby should be treated as one entity, and to be successful, any range of intervention that seek to prevent perinatal and neonatal death must address both maternal and neonatal factors. Annex 3. In this context of Nepal, many interventions that will reduce neonatal mortality are already well defined, such as those included in Safe Motherhood Program, broader reproductive health program, the integrated management of childhood illness, maternal and neonatal tetanus elimination program, immunization and nutrition initiative. Neonatal health is an important component of National Reproductive Health Strategy. The National Safe Motherhood Program, which also aims to reduce maternal and neonatal mortality, has always intended that neonatal health component be developed as a separate document. As a part of this activity, the Ministry of Health initiated the development of National Neonatal Health Strategy with support from the Saving Newborn Life Initiative, Save the Children Federation US. This strategy will describe the more specific direction and broad objective for future interventions focused directly to improve neonatal health. The neonatal health strategy is based on two key pieces of work. Firstly, a detailed situation analysis of neonatal health in Nepal completed in 2002, and second, the series of position paper produced by the Neonatal Health Working Group. This introduction only provides a very outline of the background and present status of neonatal health in Nepal. The strategy has been prepared by considering the magnitude and gravity of neonatal problem in Nepal. Great attention has been focused on evidence-based and proven intervention. Annex 2 and 4. Cost effectiveness of intervention, acceptability, including innovativeness of approach, and the capacity of community health and other systems in the country were other factors considered too. A brief summary of neonatal health status in Nepal. In Nepal, infant and neonatal mortality and morbidity is very high. MMR 64 and neonatal mortality is 39 per thousand live birth, and PMR 47.4 per thousand live birth, and stillbirth It is estimated that in Nepal, nearly 50,000 children under 1 year of age die every 12 months. Two-thirds of them die within 28 days of age, resulting in over 30,000 neonatal deaths per year. Among these dying within the neonatal period, 20,000, two-thirds die in the first week of life. Nearly the same number of babies are stillborn. More than 16,000 of those dying within the first week of life dying within 24 hours. As things stand, this means that 3 to 4 newborns are dying every hour in Nepal. As things stand, this means that 3 to 4 newborns are dying every hour in Nepal. There has been a remarkable decline in infant mortality rates in Nepal over the past 15 years, from 130 in 1987 to 64 in 2001. However, this has not been matched by a similar fall in neonatal mortality, which has decreased from 45.2 in 1987 to 38.6 in 2001. In Expo, consequently, neonatal mortality has risen from 40% to 60% as a proportion of infant mortality. Further significant reduction in neonatal and infant and child mortality rate will largely be dependent on reducing neonatal mortality. There are no population-based studies that describe the pattern of the direct causes of neonatal death available for Nepal. See Annex 7 for selected demographic information related to newborn health. Hospital-based data suggests that the major direct causes of neonatal death in Nepal are infection, birth asphyxia, trauma, prematurity, hypothermia. Underlying these direct causes in consultation of underlying causes including poor pre-pregnancy health, inadequate care during pregnancy, inadequate care during delivery, low birth weight, and inadequate newborn and postpartum care. Fundamental to these underlying causes is the low status and priority given to women and newborn. Only half of the Nepalese women receive any antenatal care from a trained health worker, and only 14% attend 4 or more times. The several common preventable and treatable maternal infections that affect fetal survival, such as syphilis and other STI, malaria, urinary tract infection, and tetanus. Only 1 in 4 women report receiving any iron folate during pregnancy, and 75% are anemic. Half of all pregnant women receive no tetanus toxoid during their pregnancy. This state of affairs is strongly negatively associated with maternal education. Nearly 90% of women deliver at home, and 55% of deliver with assistance of the friend or relative. Only 9% home birth or clean delivery kits use a health worker assisted. Only 13% deliveries TBAs attend. About a quarter of all delivery referral systems often are not functional, and where they are receiving facility may be unable to provide service for maternal and neonatal complication. The National Safe Motherhood Program recommended that mothers should have a postnatal checkup within 2 days of delivery, but less than 20% mothers receive this service. Breastfeeding is almost universal in Nepal and continues for a mean of 29 months, but immediate and exclusive breastfeeding is often not practiced, and colostrum is discarded in nearly a third of cases. 40% of neonatal receive a prelactal feed, and initiation of breastfeeding is delayed for more than 24 hours for a third of neonatal. Appropriate care for a normal newborn is neither widely understood nor practiced in the community or health system. The traditional attitude and practice dominate newborn care and are often hazardous. Hypothermia has been shown to be an important cause of neonatal morbidity in hospital setting in Nepal. Neonatal danger signs are commonly not recognized, whilst harmless conditions often lead to the unnecessary referral. A study of low birth weight from 4 regional hospitals has found a weighted mean incidence of 27%. The strongest risk factor for low birth weight were maternal weight, previous preterm delivery, short birth interval, and paternal employment in agriculture. More than 1 in 5 pregnant women in Nepal use tobacco. Strategy direction in the context of Nepal. The National Neonatal Strategy recognized that attempting to tackle all the issues surrounding neonatal mortality immediately is unrealistic. The key statistics to consider when setting priorities for intervention to reduce neonatal mortality in Nepal is that 90% of birth takes place in home in the absence of skilled attendant. Therefore, proven intervention addressing cause of maternal and neonatal complication at family and community level will be primary focus for immediate impact. This intervention will require the establishment of a chain of care linking families and community with the health system to bring about medium to long term impact. Intervention that improve women's nutrition, education, access to resources need to be addressed. These interventions, which address the underlying cause, will be initially simultaneously through multi-sectoral action. Advocacy for resource mobilization at different levels will be a major strategic aim for improving neonatal and maternal health. Goals and objectives. Goals: to improve the health and survival of newborn babies in Nepal. Strategic objective: to achieve a sustainable increase in the adoption of healthy newborn care practices and reduce prevailing harmful practices. To strengthen the quality of promotive, preventive and curative neonatal health services at all levels. Sub-strategic objective: to make the care of normal newborn the foundation of intervention for improving neonatal health in Nepal. To strengthen and expand evidence-based, cost-effective newborn health care intervention, promotive, preventive and curative at all levels. To pilot and refine innovative local program and to adopt scale of promising models. To identify and address specific practices which are either harmful or not based on sound evidence. To promote accurately targeted research to fill gap in knowledge and practice. To mobilize internal and external commitment and resources. Strategic intervention: the MOH will seek to achieve the above objective by prioritizing the following intervention. To be successful, both inter and intra-sectoral coordination, cooperation and collaboration must be realized. The major priority intervention can be categorized under the 5 main headings: policy, behavior change communication, strengthening health service delivery, strengthening program management and research. Policy: the National Neonatal Health Strategy will establish within the present Safe Motherhood Subcommittee a neonatal group which is also represented by members of the Child Health Subcommittee. Institute Family Health Division is a focal point for neonatal health activity. Ensure close collaboration with Safe Motherhood Program and other related program. Facilitate the institutionalization of neonatal care as a sub-speciality with appropriate training courses both in service and pre-service for different cadres of health worker at the tertiary and secondary level of care. Promote piloting of promising interventions followed by scaling of successful one. Ensure the activation of National Breastfeeding Promotion and Protection Committee to monitor health facility baby friendly status and adherence to Nepal Code for marketing of breast milk substitute. Support and coordinate for the strengthening of health system of universal registration of all birth and death. Ensure gender equality into the neonatal care. In Annex, monitoring baby friendly status and future potential developments such as mother and baby friendly status involve appraising, awarding and removing such status. Child mortality rates are significantly higher for girls than boys, and although neonatal mortality rates do not show this difference, this may be due to incomplete or biased reporting. The National Neonatal Health Strategy recognizes that there are national policy objectives described elsewhere that will have an important effect on reducing neonatal mortality. Annex 7, notably increasing family planning coverage, which will reduce neonatal mortality through birth spacing. Behavior change communication. In order to address the newborn care practices at family and community level, the National Neonatal Health Strategy promotes development of a national neonatal BCC strategy with a package containing key messages promoting newborn care. that complement the national IEC strategy developed for the Safe Motherhood and Child Health Program and is integrated with neonatal policy strategy and guideline.